Thank you, Jean-Louis. It's very nice to be here. We've had a wonderful time in the Maritimes. Jean-Louis' introduction is exactly what I want to talk about. It's about moving beyond the sort of conceptual issues that are in the chronic care model to the work that has to go on in the front line to create good outcomes for our patients with major chronic illnesses. So it's that execution that Jean-Louis was talking about that I want to talk about with you this morning. Just some history to sort of put the chronic care model into some historical context, both to remind us of where we've been, where we are, and then a little bit more about where we're going. So where we are, or where we've been, it was summarized in the United States by an Institute of Medicine report. How many are familiar with this report? The quality, many of you. Well, that's good. We think of it as biblical. So when I go to a hotel and I open the drawer, I expect to see this and not the Gideon book, any rate. And what this book established clearly is that the quality of care in the United States was mediocre at best, something that our Republican friends haven't come to grips with, but the rest of us have. And that the problem wasn't the quality or the intelligence or the industriousness of the people working in healthcare. The problem was the system in which they were working. So they were working in a system that almost guaranteed, as IHI likes to say, the system it's the system, stupid. It's the system that really creates outcomes. And that, therefore, the only approach to quality improvement that makes any sense is to change the system. And that's what you were all working on. So what all of us were working on in the 1980s and 90s was what's wrong with the system? What creates this gap between what is possible from best practice and the real world? That's the quality chasm. And it became clear that it was a system that was oriented to the treatment of acute illness, which makes perfect sense if you think about the history of demography and illness. When my father went into practice in the 1930s, most of what he saw was younger people with acute infectious disease, injuries, and so on. And the goal was to get them well and back to work. So an acute orientation made a lot of sense. The problem was that lots changed between the 1930s and this millennium, especially with respect to the population, which got much older, much sicker because they're older. People were living longer because of improvements in care with chronic illness. So general practice went from family practice when my father opened his office to really adult, even geriatric chronic disease practice currently. And we're still using the old acute care model of responding to whatever problem brings the patient in, sending them home with a prescription, and then if they didn't get better, asking them to come back, but assuming that you might never see them again. A model that clearly isn't going to work for people with major chronic illness. So the system has changed. I'm not taking credit for it, but if we helped a little bit, that's wonderful. But just to show you the impact of changing the system, I don't know how many saw this article in the New England Journal of Medicine in April of this year. This was from our Centers for Disease Control, and it summarizes the incidence of major complications of diabetes in 1990, 2000, and 2010 across the United States. And you can see, first of all, patients with I can't call them diabetics. They'd get very upset. So I swallowed that one. And I'm going to call them people with diabetes. People with diabetes, of course, have much higher incidences of those conditions. Heart attack, stroke, amputation, end-stage renal disease, as you see. What's striking, of course, is the dramatic decline in the incidence of those complications over the 20-year interval. So the question that the authors of this paper were addressing is what is responsible for the decline? Did we discover some magical cure for diabetes? Well, I think you all know we didn't. So what was it? Well, here's what the authors of the article concluded, that it's an increased emphasis on the integrated management of care for patients with chronic diseases, including enhancements in team-based care. Write that down because we're going to talk a lot more about that. Patient education, I prefer to call it self-management support, like the assistant minister did. Improvements in disease management, and we'll talk about that. It's really around follow-up and care management, and clinical decision support. Care more in accord with evidence-based guidelines. So that's what led to this dramatic reduction. So do we stop and declare victory? And obviously the answer is no. Those rates in 1990 were obscenely high, and we've brought them down through better care to reasonable rates, but we can do much better, and the article makes that point. So where did the chronic care model come from, and where does all of our work need to continue to reside? It needs to reside in the evidence of what works. That's where it started. In the 1990s, we were trying to improve diabetes care for our 20,000 diabetics in the Pacific Northwest, and looking at the literature, looking for ideas for ways to change the system. We knew we had to change the system, we just didn't know how. And remarkably, we found a fair amount of evidence, some of which we summarized with the, I can't say the assistants, we assisted friends in the Netherlands in a Cochrane collaboration review of what improves care for diabetics in primary care. And we found about 40 studies, and we found that they covered very different aspects of the system. Some aspects were at trying to improve the ability of the providers to practice evidence-based medicine, clinical education, clinical reminders, that sort of thing. Some interventions were directed at patients, helping patients become better self-managers of their condition. Some were directed at information technology, because this was an era in which electronic medical records were just getting started. And some were directed at reorganizing the way care was delivered, different kinds of visits, different involvement of various members of the practice team in care, those kinds of things. We then did a little reanalysis of this work in the early part of this millennium, which we published in JAMA, and we found that the more of these different areas that were touched by an intervention, the better the outcomes. So if you did something to improve the decision making of the provider, help patients become better self-managers, improve information systems so that they had better control of their population and so on, the more of those things you did, the better the outcomes. And that's really the origins of the chronic care model. This was a meta-analysis of, again, I'm using diabetes because many of you are working on diabetes, and it's been kind of our sort of place to begin. Although we've gotten accused of being single disease oriented, and I want to let you all know that we are not single disease oriented. Much of what we're doing now is for the multi-morbid patient with multiple chronic conditions. But most of the research has been done with single conditions, and that's why I'm showing it to you. This was done by a Canadian, Kavi Shojania, who's now at the University of Toronto, showing, again, the impact of various kinds of interventions on primary care practice and their impact on hemoglobin A1C levels. And you all, I'm sure, anybody who's working on diabetes is looking at hemoglobin A1C levels. It's the best indicator of glycemic control. How many are familiar with meta-analysis charting? So the vertical line indicates no effect. Dots to the right of the line would suggest that the intervention was actually associated with an increase in hemoglobin A1C. So dots to the left of the line show improvement in hemoglobin A1C related to that particular class of intervention. So you can see all the dots are to the left, and if you read down the list, you'll see, again, a hodgepodge of things directed at patients, things directed at providers, things directed at the organization of practice, things directed at information technology. It's just a recurring theme. Notice, though, what is number one. The involvement of the non-provider members of practice teams in the care of patients. If I could show you the exact same meta-analytic chart for people with hypertension, and it would look exactly the same. So we're beginning to understand the importance of supporting providers with a multidisciplinary team who are not just giving the provider instruments for them to do all the work, but are actually playing active roles in patient care. And that is associated with the biggest improvements in outcomes, in hemoglobin A1C. And I think given how remote some of your communities are, this is an encouraging finding, because it suggests that people other than providers can make a major difference in the management of people with chronic illness. So this is the chronic care model, and again, now you know a little bit more perhaps than you did about where it came from. Now what I'd like to talk about is sort of where it's going and what we're learning about it as we've now worked with it for 15 or so years. Before I leave it, though, there is now pretty solid evidence that interventions that are based on the chronic care model actually do make a difference. And we'll leave you these slides so that if you want to see some of this evidence, you're welcome to look at it for yourselves. But we constantly are reminded that the chronic care model is not a complete model of patient care. And we certainly agree with that, never intended it to be a complete model of patient care. It is a model of reorganizing systems to take better care of people with chronic problems. But it's not intended to be a map for what primary care in total should look like. And we recognize that patients with chronic illness need, in addition to those interventions associated with the chronic care model, they need a more effective primary care home, which is the terminology we're using in the States. And it's not bad terminology, although you sure wouldn't want to live in your doctor's office. But you do want chronic care model type care rendered by people that know you, the patient, as a human being, as an individual, as an employee, as a parent, and so on. So-called whole person knowledge that the patient-centered folks like Moira Stewart have talked about for many years. And we've also learned as illness gets more complicated, as patients are getting older with multiple chronic conditions, that we need to find more efficient ways of getting specialist expertise into the management of these people without creating a whole new complicated specialty care system. Trying to keep the patients primarily in primary care, but bringing specialist expertise to that care. So what's happened in the United States is that there has been, in partial response to the Affordable Care Act and the recognition that the foundation of any good national health care system is a robust primary care sector, there has been an effort to try to rejuvenate and improve primary care, and a recognition that there was a new model needed. And the new model is called the patient-centered medical home. How many are familiar with that terminology? What the patient-centered medical home model in the United States is really an amalgamation of two models. One, the chronic care model, because the chronic care model talks about how care is organized and delivered, but recognizing that there's a lot that isn't in the chronic care model, as we talked about a minute ago. So the other part of the other model is a model that came from Pediatrics, the pediatric medical home model, which interestingly enough grew up in academic children's hospitals where children with chronic diseases like cystic fibrosis would be taken care of by 5 different specialty groups: pulmonology, gastroenterology, endocrinology, and so on. And the parents were going crazy because they never knew who to talk to about their child. Who was in charge? Well, the pulmonologist would say, well, you know, I'm in charge of the lungs, but I can't tell you about their nutrition. And the gastroenterologist would say, I can tell you about their nutrition, but I can't tell you about their lungs. And the parents were going crazy and said, you've got to do something. So what did they do? They put a general pediatrician in the middle of all of that and called that the pediatric medical home. And the general pediatrician dealt with the parents, the information, the coordination, the bringing together, the synthesis of information, and the like. So that looked like a nice model of what good primary care looks like. So those are the two models that were put together to create the patient-centered medical home. So for the last, 6 or 7 years, we've been engaged in a variety of projects trying to help busy primary care practices with a heavy emphasis on safety net practices, because that's where our hearts and much of our work is with practices that are serving low-income and minority populations. Help them transform themselves into patient-centered medical homes. So one of the issues that I know you're all interested in is how do you engage practices in improvement? And it's, of course, we've been struggling with that question for a long time. And I don't have any magic answers. The only thing I can say is that in the absence of measurement, it is very difficult to engage a practice in improvement because no practice thinks it's doing a bad job. No place. I'm sure Canada is no different. And until you can show them trusted, believable metrics, they are not going to go to the trouble of transforming themselves. So that's the only message I can give you. Financial incentives are now being experimented with all over the U.S., and I think our experience with financial incentives is that they bring people to the table, or let me put it this way, they bring people to the dance hall. They don't make them dance, if you get my drift. What we are learning, though, is what's the difference between practices that successfully transform, successfully can change their systems of care and change their outcomes for their patients, and practices that don't. Practices that come to these sessions, seem to have a good time, seem to be doing a good job, but then when you measure, you don't see anything. One, successful practices view performance as a system property. They get that system issue, and they realize that they've got to change their system, and not just, as we like to call it, tinker around the edges. How many of you are familiar with a person from British Columbia named Connie Davis? A few of you. Connie, I learned a lot from Connie. Connie used to work with us before she moved to Canada. And she liked to analogize the way many practices would deal with something like the chronic care model is they would build a screen porch. They wouldn't change their house. They wouldn't change the heating system or anything basic in the house. They'd just add a screen porch onto the old house. But the old house functioned the same old way. So they recognized the importance of changing systems. Successful practices are restless. They're always asking, can we do it better? And outside folks like yourselves and practice coaches can really make a difference in helping create that restlessness that makes for a good practice. Breaking the complacency, well, it's a combination of complacency and exhaustion, because primary care is hard work. And then, as I mentioned a minute ago, intrinsic, what the psychologists call intrinsic motivation, which means I'm doing something because I feel it inside. I want to do better. I'm disturbed because my metrics aren't as good as they could be. That's intrinsic motivation. it comes out of behavior change. Intrinsic motivation to stop smoking is you know, I don't want to die of lung cancer, so I'm going to do this for my own health and myself. That's intrinsic. Extrinsic is my employer is going to give us $50 if we stop smoking. That's extrinsic. Intrinsic is much more powerful. Systems that improve their metrics generally have undergone fairly major transformation. So if they are just tinkering, then you're not going to see the metrics improve. Metrics improve when there are really wholesale kinds of changes going on. And transformation generally means that they change the basics of how care delivered, the when, the how, and the by whom care is delivered. So that if you walk into a practice before transformation, what you will generally see is most of the work is being done by the providers. If you walk in after transformation, you'll see care often begins at the front desk and is then picked up by the medical assistant. The prevention is often done before the provider even walks into the office, that sort of thing. So the who, when, by whom changes. People are taking on new roles, critical part of transformation, especially the non-provider members of the practice team. And the roles are generally upscaling of their roles. The phrase that is now in frequent use in the United States is getting people to the top of their license. Is that a familiar phrase here? Okay, so you know what I mean. So that's what you'll see, role expansion for most of the people on a practice team. Sometimes you'll see new staff, and a place that you'll frequently see new staff is around the function care management, which I'll describe in more detail in a minute. And then, of course, transformation is stressful, and so an important part of helping a practice through transformation is helping them deal with the turmoil and stress of being transformed. Now, a major for us, major transition in our thinking was people would say, you know, the chronic care model is lovely, self-management support, delivery system design, that all makes sense, but what does that actually mean in terms of the work that we do? And so what we've been looking at is what specific functions, roles, whatever you want to call it, do those chronic care model elements translate to that actually leads to better care and better outcomes. And this is what we see. Care by the team, not just by the provider. And we'll talk more about what that means. Managing populations, not just individual patients. How many are familiar with the term population management? Panel management, it's sometimes called. Transformed practices with good metrics are now experts at population management. Planned proactive care. And planned care, we once called the chronic care model the planned care model because we were trying to move away from acute reactive care to more organized care with an agenda for people with chronic illness. But now, over 15 years, we see what planned care really looks like, and I can tell you exactly what they're doing. Self-management support, same thing. Lofty term, but what do good practices actually do to help patients become better self-managers of their illness. Medication management is something that wasn't high on our radar list initially, but as time has gone on, we've recognized that practices that manage medications well have definitely get better outcomes. Care management and follow-up, I've mentioned. Follow-up is absolutely critical, and high-performing practices organize follow-up. They don't just give an appointment for come back in 6 weeks or 6 months. Follow-up is much more proactive than that, and we'll talk about it. And then lastly, coordinating care, because patients with chronic illness are frequently crossing boundaries between providers, between institutions, and every time one crosses a boundary, there is a risk of mishap, a risk of misinformation, and so on. So let's start with team care, because as you remember, it is the single most powerful intervention. So team involvement in the care of chronically ill people is the single most powerful intervention. Like I just said, I should have looked at my slide first. Without effective teams, though, practices really do find it difficult to do many of the other functions. A provider can't see a busy day of 18, 20, 22, 24 patients and do population management and do follow-up phone calls. So this is why the team becomes the vehicle for doing all of these other functions well. How do effective practices create effective teams? Well, first of all, they're hiring differently than they used to. We used to hire based on experience, certification, training, and now people are looking more for interpersonal skills, ambition, energy, creativity, and so on. In our bad economy, now there are a large number of recent college graduates, enthusiastic, bright, young people who are easily trainable in all sorts of things that can be supportive of healthcare, and that's who they're bringing into practice. Second, they define the key roles, those functions that I just talked about, population management, et cetera, and they delegate those roles to the various members of the team, make sure they're trained to do those roles, and then let them do it. They train, they use protocols and standing orders to the limits that the law allows to allow people to operate as independently as possible, so that people don't have to keep going back to the provider. Is it okay if I do this? Is it okay if I do that? Standing orders frees people up to operate independently as their training should allow. And then critical is giving teams time to meet. It's one thing to say we believe in teams, and then if there's never any time allowed for that group to meet, it's hard for it to function as a team. Make sense? Population management. Many of the deficiencies in chronic care and in care in general relate to the reactive nature of medicine. Of somebody coming in with a relatively acute problem, and it drowns out all of those other preventive and chronic care needs because of the tyranny of the urgent, as some people like to talk about. But now that we have information that allows us to clearly define panels and use information technology tools to say who in my practice has diabetes, Which of those has a hemoglobin A1C above 8.5? Which of those haven't we seen in the last 6 months? Let's call them up and get them in. That's population management. And in our view, it is often the institution of aggressive population management that leads to the biggest change in metrics. And I think you can see why, because you're dealing with larger numbers of people and you're not just waiting for people to come in to improve their outcomes. Linking assessment with outreach, as I said, may account for some of the biggest changes in outcome. Remember I mentioned planned proactive care. That's always been a critical part. So how do practices do planned proactive care? And now if you walk into a good practice in the United States, and if anybody's interested, I can tell you some good practices, some just across the border in Maine. What do? Well, first of all, they identify the key clinical tasks associated with the provision of evidence-based care. This is back to the organization of teams. They decide who on the team should do the task and they make sure they're trained. So that's back to the establishing an effective team. They then, if you walk into a good practice in the U.S. now at about 8 o'clock in the morning, you will see each provider meeting with their medical assistant, and if they're lucky enough to have a nurse, their nurse, and they're going over who's coming in today. And what do their data look like? When was their last hemoglobin A1C? Did they get their flu shot? Has she had her mammogram? All of that is done in a 15-minute huddle first thing in the morning, so they know exactly what every patient who's coming in needs to be up to date with their prevention and their chronic illness. And then the members of the team are already organized to actually perform those functions. So let's say, again, to play this diabetes song, let's say it's a patient who needs a monofilament foot examination, which is a part of every evidence-based guideline that I'm aware of. Well, providers in good practices don't do monofilament exams. First of all, they're too busy, and they often don't do them as well as somebody who's really trained to do them systematically. So they'll train somebody on the team, and that person, before the provider even goes in the door, will have the monofilament exam done and charted. And that's how you do planned proactive care. How do effective teams implement self-management support? Well, the first thing they do is they realize that self-management is providing self-management for patients with multiple chronic illnesses is complicated. They need disease-specific information that sometimes needs to be fairly specialized if it's a less common chronic illness. So they need to establish linkages with programs and institutions and individuals in their community that can provide those services. Make sense? But that's not enough. That's clearly not enough, because there's now evidence that self-management is something that needs to be constantly reinforced, reviewed, re-energized, because it's hard work. So they try to figure out within their practice team a way of providing self-management support on a routine basis. So they identify individuals on the practice team with good interpersonal skills, train them in appropriate self-management counseling techniques like motivational interviewing everybody familiar with it? And then they become the self-management support person for the practice. And often there are several in practices of any size. They try to integrate at least some degree of self-management counseling into every encounter. And that often means a review of self-management goals, updating of action plans, seeing what barriers the patient has encountered, helping them overcome those barriers. Things that I think you're all familiar with. It's just a matter of making it a routine part of office encounters. So that's what you'll see in a successful practice. What are successful practices doing to more effectively manage medications? Well, there is growing evidence that treating to target really does make a difference. And by treating to target, it means having, first of all, developing a target, whether it's a hemoglobin A1C of 7 or a blood pressure of 130/80, whatever the target is, and then managing to try to reach that target. Is it possible to reach targets for every patient? Of course not. But at least you can try and try to find some balance between drug toxicity, obviously, and reaching target. But this focus on trying to get to a target really in the literature now seems to be a very important tool towards getting metrics improved. Second, medication reconciliation. Is that what it's called here? So you all know what I mean. I mean, historically it meant put all your medicines in a brown bag, bring them in, and then everybody goes through them, throw this in a trash can, you know. But medication reconciliation now has become a fairly sophisticated process, especially with multimorbidity and polypharmacy. When I was practicing, my average type 2 diabetic patient was on 2 drugs, maybe 3. Now the average type 2 diabetic in our system is on 8 to 12 medications. So lots of opportunities for non-adherence, for drug interactions, for patient errors in drug taking. So medication reconciliation on a regular basis really becomes a critical element of good chronic illness care. Pharmacists and nurses, when practices are fortunate enough to have them, can play a critical role in improving in treating to target because with standing orders in many places, they can independently titrate medications, often without visits, by email, by telephone, so on. Just adding to the ability of the practice to help patients reach targets. I can't emphasize enough the importance of follow-up. And relying on repeat visits as the only tool for follow-up is fraught with problems. It's expensive for patients. It's time-consuming for the practice. It's often relying on the patient to keep appointments that they may feel they don't need, and so on. So proactive follow-up that doesn't depend on repeat visits is increasingly being used by effective practices, whether it's by phone, or by email, by patient portal, by carrier pigeon. It really doesn't matter as long as there is communication, monitoring of key metrics to see how patients are doing so patients aren't lost to follow-up. Lost to follow-up is a recipe for poor outcomes. I love this study, and I'm not just flattering you because it was in the Canadian Medical Association Journal, and it happens to relate to First Nation people. But I love this study for two reasons. It's a randomized trial of care for diabetic First Nation people, and they randomized the patients to two groups. One group got home visits by a nurse, and if the nurse saw an issue like with medications, then she would consult with the provider, and then the provider would make whatever change the provider wanted to make. That was the control group. The intervention group, are you familiar with this study? The intervention group, you are, Steve. The intervention group, same thing, except the nurse had orders, standing orders, that allowed her to change the medications in accord with protocol. Make sense? So, and here you can see the effect. Even the control group, a 20% reduction in, a 20 millimeter reduction in systolic blood pressure just by having a nurse visit. The power of follow-up. That's even if she couldn't do much except visit. And then if you gave her the tools to change medication, you got another 10 millimeters of mercury improvement. I like the study because of it shows just how powerful routine, proactive follow-up that doesn't depend on office visits can be. I mentioned earlier this growing importance of care management, and it's as patients are getting older, as the number of chronic illnesses per patient is increasing, patient complexity increasing, patient frailty increasing, primary care is finding that it needs to be able to intensify its ability to provide follow-up. So with those kinds of more complex, frailer patients, you can't just rely on phone calls. And so this is where care management now is all the rage in the United States. And what is it? It is more intensive follow-up, generally by a nurse, who is operating often in concert with the practice, but somewhat independently, providing medication management, self-management support, follow-up, and then often trying also to coordinate care between multiple providers who may be caring for that particular patient. So that's what we mean by care management. A lot of money is now being spent on care management. The problem is that if you look at the literature and if you look at real practices that are measuring performance, we're seeing a wide variation in how successful those interventions are. And there's now more and more research being directed at trying to distinguish what works in care management from what doesn't. And what seems to work is in the far right-hand box here. What seems to work is when the care manager is an integral member of the team that's taking care of the patient. Number one. Number two, when the care manager can influence drugs, like our nurses with the First Nations people. When the care managers have access to experts and often specialists in the particular disease that is dominating the patient's health problem. So if it's a patient with severe heart failure, if the care manager has access to cardiology, that can get help from cardiology in managing the medications, the outcomes are a little better. And then a lot of care management has been done exclusively by telephone, and the evidence suggests that at least some face-to-face contact seems to be important, not surprisingly. So care management, keep your eyes on that. There's an awful lot of attention being paid to it, but I think it is an important adjunct for the care of older, sicker patients, but it's clear from the literature it has to be done properly to get the effects. And then lastly, effective practices are taking care coordination much more seriously, and they're recognizing the dangers associated with poorly coordinated, fragmented care. Patients can see the best providers in the world, but if those providers are not talking to each other, patients get into trouble. They get interacting drugs. They get things not done because the assumption is. And all of that is preventable by effective care coordination. We've done some studies of what effective practices do to coordinate care, and I can summarize it with these 4 relatively simple things. 1, practices that coordinate care well, or institutions that coordinate care well, assume the accountability themselves. They don't sit there and say, the problem is the specialist won't talk to me. They take action. They assume accountability. Second, they support their patients when their patients cross boundaries. So what do I mean? If a patient is referred to a key specialty consultation, the primary care practice helps the patient make the appointment, makes sure they get the appointment, makes sure that the specialist gets the proper patient information so that they can do the job and answer the question, and make sure that the specialist gets the information back to primary care that primary care sent them for in the first place. So that's what I mean by provide patient support. Third, they build relationships. And at least in the U.S., increasingly, primary care is fairly isolated from the rest of medical practice. Specialists now are often hospital-based. Primary care is no longer seeing patients in the hospital except in rural areas. So often referrals are going to strangers. So that the kinds of relationships that my father had when everybody was in the hospital, drinking coffee in the doctor's lounge every morning, talking over patients, going to the same room to see their patient together, and then having curbside consultation, all that is gone for much of American medicine now. So we need to rebuild those relationships, and that's what good practices are doing. So they'll go to the best cardiology group in the community and they'll say, we want to send our patients to you, but we want you to understand what we expect, and we want to understand what you expect. And they're actually having these conversations. They're actually signing contracts in some places, and it's working much better. And then lastly, they develop ways of transmitting information that is reliable, so that patient information gets to where it's needed in a timely way. So that's where we are, and I think where we're headed. So we're headed to melding the chronic care model with better primary care, better care coordination, better access, more continuity, better understanding of patients as people, but combining it with systems that reliably deliver the services that meet the needs of patients with chronic illness. I welcome your questions. Thank you very much.